Queres ficar com?
Eu e a Rita tratamos aqui mais no chat. Tratamos no chat e passar os slides, certo? Da Rita. Slide inicial.
Exatamente, para passar os slides. Precisa disto. Vai olhar, vai ver aquilo ali, mas é com esse rato.
Falta,
Ali ou aqui.
falta só confirmar o Dr. Delphi. Dr. Delphi, can you hear us, please? Can you try to speak, please?
I can hear you, but apparently you don't hear me.
Yes, we can. Now we can.
Oh,
Thank you so
finally,
much.
Do you want me to share my screen to test or not? It's too late.
Now, if you don't mind, try to share, please.
Ok.
Se ficar assim, certo? Pode ficar assim.
Exato, exato. Ela tem que parar, que é para ela testar o dela.
Ok.
Okay, we are seeing PowerPoint, not in full screen mode.
Is it okay now?
Okay, full screen mode. Thank you so much.
Okay.
Okay, good morning, good Afternoon, good evening to you wherever you are, and a very, very warm welcome to this deep dive, this RAGNA deep dive on surveillance and data collection that's being hosted by our colleagues at INFARMED. We have a very exciting program to look forward to today, but before we get started, I just want to mention that at the next RAGNA meeting, for those members of RAGNA regulatory agencies that will participate, that we are looking to share experience focused on this topic. So if you're interested to do that, please don't hesitate to contact the RAGNA Secretariat. So on behalf of RAGNA, the RAGNA Secretariat, very warm welcome. And without much further ado, I just want to say a very warm thank you, obrigada, to our colleagues at INFARMED in Portugal, and hand over to Carlos and his colleagues to take us through this deep dive.
Thank you, Asa. And first of all, of course, on behalf of INFARMED, thank you very much to RAGNA for all the work that has been done, and that we are also a little bit part of it, and have witnessed the efforts that you have been doing in this area. Again, welcome everybody, and a special thank to all the participants that will be presenting the different topics. And without further delays, I would start by presenting Professor Martina Escher, who is Technical Officer for Antimicrobial Use Surveillance at WHO Geneva. She holds a doctorate in veterinary medicine and a PhD, and has successfully completed the European Field Epidemiology training. With extensive experience in epidemiology and antimicrobial resistance, she's currently leading the National GLASS Antimicrobial Use Data Collection, Analysis and Reporting efforts. So she will be presenting the topic WHO GLASS and the AWARE system, strengthening global surveillance to tackle antimicrobial resistance. Professor Martina, thank you very much.
Thank you very much. I hope everyone can hear me.
Yes, we can hear you perfectly.
Thank you. So just thank you also for the professor. I'm not a professor, but thank you for this. No problem. I mean, you were enhancing my position. So I said I'm working at the WHO headquarters, and in the antimicrobial resistance department, and I'm mainly focusing my activities on antimicrobial use monitoring. And I'm pleased to provide you some insight on how WHO GLASS and the AWARE system strengthen global surveillance to tackle AMR. We are all aware that AMR is indeed a major issue in human health, but also in animal, and we will see further information in other sector. And in 2015, in fact, the World Health Assembly endorsed the Global Action Plan on AMR. This is under revision with the aim of ensuring continuity of successful treatment and prevention of infectious diseases with effective, safe, quality assured medicines that are used in responsible way and accessible to all who need them. There were 5 strategic objectives, and it was very much highlighted the importance of strengthening the knowledge and evidence based through surveillance research, both in AMR and antimicrobial use, and to optimize the use of antimicrobial medicines. In response to that, WHO takes several actions and initiated several projects. The WHO AWARE system, Access Watch Reserve, was developed to support, it was and has been developed over the years to support antimicrobial stewardship and optimize antibiotic use globally by promoting appropriate antibiotic use, by guiding medicine regulatory agencies and prescribers to select safer and active options, avoiding unnecessary use of antibiotics, and reducing or increasing appropriate use of broad spectrum, reducing inappropriate use of broad spectrum
Martina?
and last. Yes?
Could you please put the presentation in presentation mode, because it's
Oh,
stuck.
I'm sorry, because I could see. Can you see it in presentation mode?
Not yet.
Because in my computer it is.
Oh.
I apologize for this.
And
I don't know. Do you?
yeah, that should be.
Perhaps try to share the screen instead of PowerPoint. Try to share the screen
Okay.
where the presentation is.
Okay, stop sharing. Oh, I apologize for this.
No problem.
Share. It's my entire screen. Share. Is it now in presentation mode?
Yes, perfect.
Okay, apologies. After all this year of webinar, we are still facing some challenges. So the importance of the AWARE system is really to promote appropriate antibiotic use, to provide some indicators to monitor and benchmark antibiotic use, and supports therefore surveillance and stewardship programs at local, national, and global level. And of course, finally, combating antimicrobial resistance by minimizing misuse and preserving antibiotic effectiveness. There are two main tools. One is the WHO, the AWARE classification, which is linked to the WHO Essential Medicine List, and the other was published in 2022 and is the AWARE Antibiotic Book. In support of this, is not WHO alone, there is a technical advisory group on AWARE, and a new one was established this year. You can access the website through the QR code. Now I cannot move to the next. Okay. The classification, the Aware Access Watch Reserve classification, was first published in 2017, and it was latest. The latest update was issued in 2025. It now classifies over. It classifies. Over 200 antibiotics in Access Watch and Reserve Reserve class, and also over 100 in the non-recommended antibiotic class. Access antibiotics, what are those that are usually have a lower cost, are highly safe for patient, and are indicated as first choice to treat most of the community infections. Watch antibiotics such as third generation cephalosporins, ceftriaxone, ceftriaxone, or azithromycin cephalosporins. These are antibiotics that are usually need to be used to treat more severe infections, and have a higher potential for resistance, and these are very much targets for stewardship intervention. Finally, the last resort option are antibiotics that are the last option to treat multi-resistance infections, and indeed stewardship intervention needs to monitor, stewardship program needs to ensure that these are used only when are deeply needed. The non-recommended groups was added later, and it includes fixed dose combination of multiple broad spectrum antibiotics whose use is not supported by evidence and guidelines. And in principle, these antibiotics do not need to be in the market, in principle. This was coupled with the classification was coupled with the WHO Aware Antibiotic Book that provide a more comprehensive resource to optimize antibiotic use by supporting antimicrobial stewardship at all levels of the health system. What does it do? It provides guidance on the management of more than 30 common infections, both in adults and children, and in primary health care and hospital settings. It provides first and second choice of essential antibiotics. It only includes here the antibiotics that are listed in the WHO essential medicine list. When it is possible, it always advised not to use antibiotic therapy. Otherwise, it provides the first and second choice of antibiotics for this more than 30 common infections. It also adds additional general information, such as the epidemiology of the infection, the diagnosis, the dose which is provided as standard and not for specific case, the duration taking as principle favoring shorter duration, and it is based on review of literature, existing guidelines, and expert input. It provides also a separate chapters for reserve antibiotics. This antibiotic book is ongoing first revision, and this revision will of course take into consideration newly published WHO guidelines, such as those to treat infection in children, the meningitis and STI treatment guidelines, and also will add a chapter on also the WATCH, the aware antibiotics, and for the first time also for the antifungals. And also we realized that having the aware antibiotic book is not enough, so we are also developing tools for countries on how to apply it at the national level. The importance of the aware is also because this is a tool that can be used for global but also local indicators. At the time, there is only one global antibiotic, there is only the global target indicators with the target of 70% of the global antibiotics need to be from the access group, and this was newly endorsed last year in September 2024 at the UN General Assemblies on antimicrobial resistance. This commitment, why 70% of the total antibiotics need to be from the access group, is because most of the infection are mild and can be safely treated with access antibiotics. And in this table, there is an example of the recommended treatment for common primary infection in the aware antibiotic book, and we can say that it's mainly from access antibiotics. Next to this tool, of course, WHO responded also on the need of more evidence by starting the GLASS, the Global Antimicrobial Resistance and Use Surveillance System, that was launched in 2015, and since then it expanded. In 2020, for example, antimicrobial use monitoring was included. It aims at providing representative and accurate global monitoring of antimicrobial resistance in common bacterial and invasive fungi, as well of antimicrobial use. The key function is to develop global standards and methodology, maintain a global database, analyze and report global trends, and support countries through capacity building activities. I'm not going to go through all these, but these are the main standards and methodologies or pillars developed. You can you can use the QR code to go to the web page where you can see all of them. Importantly, for GLASS AMR, the surveillance, one of the pillars is the surveillance of antimicrobial resistance in bacterial and candida, and the national routine surveillance in slime blues of AMR is the base for reporting at the global level. For the GLASS AMU, We have three pillars: surveillance of antimicrobial use, also known as antimicrobial consumption at the national level. And this is also the one that it's the base for the national report, the global reporting of national antimicrobial use data. And then we also have methodology for the surveillance of antimicrobial use at the hospital level as routine surveillance and as point prevalence survey. And we are also developing a framework to monitor the use in primary healthcare, but this will be rather not a WHO methodology, but a composition of existing methodology. We maintain a global database through the GLASS IT platform, which is a password protected environment where national focal points that are officially nominated by countries report their data. And also we, of course, make this data publicly available through the GLASS dashboard, which is an interactive dashboard where user can access the antimicrobial use AMR data at the global regional level, but also it provides also country territorial area profiles for both. And it was lastly been updated in September 2025 with 2016 to 23 data, which were submitted by the end of 2024. Next to this, and this is our main public way of publishing the data, and try to be a bit more timely, even though at the global level is always a bit complicated to be timely. And this information are coupled with periodic reports. The last one that provides a bit interpretation of the data. The last one for antimicrobial use was issued in April and was and depicted the use of antibiotics in 2022. While I don't know if you were all aware, on Monday, the GLASS AMR team launched the Global Antibiotic Resistance Surveillance Report 2025 that depicted the status of resistance in 2023, but also provided trends. And we can see a bit of result later. Country participation in GLASS has grown over the years, and this is reassuring. We are still far from the from the target to which the country committed, that 100% of the country are capable by 2030 to report globally quality AMR and MU surveillance data. But since its inception in 2015 and first data call on AMR in 2016, we saw a broad participation. And by December 2024, we had 141 countries enrolled either in GLASS AMR, either in GLASS AMU. And this also, and this is depicted on the map you can see on the left. On the right side, you can see the increased data availability for the period 2016 to 2023. Of course, GLASS AMR, the first data call was in 2016, and it has a higher number of countries participating than in GLASS AMU. In fact, this is over 100 for GLASS AMR in 2023, while for AMU we are still around 60 countries providing quality data. Regardless this, we see an improving in country participation and providing data, but this is still unevenly distributed globally, with most of the data coming mainly from the European region and the Eastern Mediterranean region. I will now go provide a few highlights from the AMR newly published reports. This report in AMR, you can see more countries are participating, and the surveillance system is mature enough now to provide also global estimates. And this is for the first time the data provided was also modeled to be adjusted by coverage and population structure. It provides national and regional estimates for 2023, but also provide global and regional trends for 16 combination. And compare antimicrobial resistance level from GLASS versus published literature. At a glance, what this report shows is that the global level of antibiotic resistance are high and unevenly distributed across region. Increased antibiotic resistant trends are observed for over 40% of the combination of pathogen and antibiotics monitor, with gram-negative bacterials posing a broader risk. Countries with limited surveillance report higher levels of antibiotic resistance, as well of countries with weaker health system and low-income countries. This is just to show that in 2023 the antimicrobial resistance was unevenly distributed across region. In median, 1 out of 6 of the over 23 million confirmed laboratory confirmed bacterial infection worldwide demonstrated resistance to one of the antibiotics, which is 1 out of 6, meaning 17% of the reported isolates. However, the higher level were observed in Southeast Asia and Eastern Mediterranean region, where 1 out of 3 laboratory confirmed bacterial infection were resistant, and the lower were observed in the European region and Western Pacific region. This high level of resistance really demonstrated the widespread of resistance pose difficulties in treated infection, including those including bloodstream infection. For example, for watch antibiotics, there were high level resistance infection for imipenem, for carbapenem, such as imipenem, in 45% of the Acinetobacter reported, 70% of Klebsiella pneumoniae. Resistance to third generation cephalosporin was 45% in Escherichia coli and 55% in Klebsiella pneumoniae, and Staphylococcus aureus methicillin resistance was in average 27%. But most worrisome is the antimicrobial resistance rates are rising, and this is rising in over 40% of the as said, of the bacterial antibiotic combination, with a 5 to 15% range of annual relative increase in antimicrobial resistance. Here, and this increase is particularly observed in gram-negative bacterial pathogens. We can see, for example, for Klebsiella pneumoniae, the increase was about 50%, Salmonella resistance to ciprofloxacin 14%, and Escherichia coli imipen 12%. And this really highlights the issue we will face in treating this resistance infection, and the importance of providing access of reserve antibiotics where this is needed. And worrisome is also the fact that antibiotic resistance affects mainly countries with lower income and fragile health systems, posing again, this highlights the fact that in any case, we need to combat antimicrobial resistance, we need to strengthen the health system of country in an holistic approach. And also that countries with higher level of resistance may also face higher barrier in accessing appropriate diagnostics and treatment. What does the antimicrobial use data tells us? So this is the report is the 2022, but I provide some update with the 2023 data. The main findings is that considerable variation in antibiotic use is found across countries and regions. The aware-based analysis highlight urgent needs to improve antibiotic use and access to antibiotics. There is a need for more context-specific aware-based indicator and targets to guide national strategies, and in general that excessive use of watch antibiotics, oral and parenteral, need to be addressed as the low use of WHO recommended first-line antibiotics. This you can see the distribution of the overall use of antibiotic expressed as DDD per 1,000 inhabitants per day in 65 CTA reporting data in 2023. The median values was 18, meaning that 18 out of every 1,000 people take an antibiotic each day on average. And we can see wide differences with higher use depicted in reported in Southeast Asia and Western Mediterranean region, and in upper and lower middle income countries. The analysis of the use by the aware classification, these figures provide you the distribution of the relative use of the four categories, with the dots providing the median and the line providing the interquartile range. In general, overall, about 56% of the antibiotic use reported was from access antibiotics, and this is way below the 70% use. And also 1 out of 3 country is not reaching the 70% national use target of access antibiotic. Watch antibiotics in some countries is even above 60%. And interesting also, reserve antibiotic use was not reported at all by 7 countries, telling us that there are, and these are all low and middle income countries, telling us that these countries are facing some issue in accessing these reserve antibiotics. Not classified antibiotics were also reported by most of the countries, and this also should be addressed. I've almost done. I just have 2 slides, I guess. This is also to show, these slides show that we need more context-specific aware-based indicators, because proportion of access antibiotic use above 70% can be reached at different level of total antibiotic use. And also and we know that the burden of disease and healthcare system are at different level in different countries. So finally, to conclude, antimicrobial resistance and antimicrobial use surveillance are foundation for action to provide evidence to guide improved access to essential antibiotics, antimicrobial stewardship intervention, infection prevention and control measures, and to develop and adapt treatment guidelines. And the aware system is the key tool for optimizing the antibiotic use. For the classification, there are ongoing review of category for their definition and also for the fixed dose combination to be able to better measure their use. The antibiotic use, as I said, it's also been updated with new WHO guidelines and added chapter for access watch, and the also essential medicine links for antifungals. And finally, WHO is also working with external partners to develop further indicators and targets for diverse settings, based on the aware tool for diverse settings to support progress towards global goals. Thank you.
Thank you. Thank you very much, Martina. I think you provided us with a lot of data, important data, and most relevant conclusions, which is always important. So moving forward, I would like to present Dr. Lieselot Diaz-Urgberg. She is an infectious disease epidemiologist working as principal expert for antimicrobial resistance and healthcare-associated infections at the ECDC. Her work focuses on the surveillance of human antimicrobial consumption and resistance, with particular emphasis in integrating data across multi-state and One Health frameworks to inform evidence-based policy and drive public health actions. She will be addressing surveillance and data collection and overview of the ECDC work. Dr. Lieselot, welcome.
Thank you so much for that introduction, and good morning to everyone. Greetings from ECDC, Stockholm, Sweden. My name is Lotta Diaz-Högberg. I work here at the European Centre for Disease Prevention and Control, mainly coordinating surveillance activities within the section for antimicrobial resistance and healthcare-associated infections. And I can have the next slide when you are ready. So I would like to thank the organizers for inviting me to present at this meeting. I'm very happy to be here today, as I know as you all are focusing on addressing AMR through different routes of your work. And we have already seen in the previous presentation from WHO that AMR is a major public health threat globally. And this is also true for Europe and the European Union, as you will see on this slide. So based on data reported to ECDC by EU and EEA countries, we estimate that more than 35,000 people in the EU die each year as a direct consequence of antibiotic resistance. And in collaboration with OECD, there has also been estimates that patients spend over 9.5 million extra days in hospitals every year to receive treatment for the consequences of infections with resistant bacteria. And this is, of course, putting large constraints on individuals and healthcare systems. And to put this in perspective, this is equivalent to the entire acute bed capacity in Portugal in 2020. So if I can have the next slide, please. So within the European Union, AMR has been recognized as a major public health threat since many years, and this is highlighted in action plans, council recommendations, and guidelines. And I'm just showing you some examples on this slide here. And within those frameworks, the implementation of good infection prevention and control practices, promotion of research and development of novel antibiotics, as well as the importance of prudent antibiotic use is highlighted. And these documents also stress the need for robust surveillance systems for both AMR and antimicrobial consumption to guide these efforts. And I have included one vital paragraph from the 2023 EU Council recommendation on AMR, where this is explicitly spelled out. And I guess, you know, the saying that what you can't measure, you cannot change, it fits really nicely in this context. So then how do we do this in the EU? If I can have next slide, please. So I have been invited today to share some experience of surveillance of antimicrobial consumption in Europe. And at ECDC, we have several ways of monitoring consumption and use. But today I will focus on the main surveillance system we have for this purpose, the European Surveillance for Antimicrobial Consumption Network, ESACnet. So ESACnet is coordinated by ECDC. It's based on national surveillance systems in the EU-EEA countries. Our methodology is harmonized to the extent possible with the European WHO AMC network and with the WHO GLASS surveillance system that we heard Martina Escher presenting on earlier. So this means that although the data structure is not completely identical, we can still share our data with WHO and complete the pan-European and the global picture of antimicrobial consumption. We work with an annual surveillance cycle, and I'm happy to announce that this morning we published 2024 data in our public dashboard at our website. I'm including the link here for those of you that want to explore this data further. And you can see an example of the 2024 results to the right on this slide. So this map shows total consumption of antibacterials for systemic use last year. And as you can see, there is quite large variation in consumption between countries. So we need to remind ourselves that this is data from sales and reimbursement system. It does not include any patient level data. So we can actually not say that this reflects differences in appropriate use of antibiotics between the countries. But we can of course speculate if there are such large differences in infectious disease morbidity across Europe that would justify the large variation in consumption that we see in this map. And when we look into the data a bit more in detail, there are indeed indications that there are opportunities for significant reductions in consumption in the EU. Next slide, please. So to support efforts to reduce antimicrobial consumption, as well as mitigating the harmful effects of AMR, the 2023 Council recommendation of AMR that I mentioned earlier sets a number of concrete targets to be achieved by the EU as a whole in 2030, using 2019 data as a baseline. You will see all 5 targets listed on the right in this slide, and you will note that 2 of these are based on consumption data that is provided to RAGNA. Next slide, please. So the first target is to reduce total consumption of antibacterials for systemic use with 20% by 2030, taking 2019 as a baseline year. And I have included some data from previous year on this slide as well. And you can see that between 2013 and 2019, we had a slow but continuously decreasing trend in consumption in the EU. So then adding the 2030 target and then a hypothetical dashed line to just show the trajectory needed to reach this target. So looking at historical data, this looks like quite a feasible target, right? In practice, this means a reduction from 19.8 defined daily doses per 1,000 inhabitants per day in 2019 to 15.9 in 2030. But let's then see how we are doing. If I can aim next slide. Yeah. Well, you will note this very sharp decrease in consumption during the pandemic years of 2020 and 2021, where we were actually very close to achieving the target already. But you will then see how consumption rebounded back to pre-pandemic levels in 2022, putting us clearly above the trajectory needed and actually above the value of the baseline year with higher consumption in 2024 compared to 2019. Next slide, please. Let's take a closer look to what happened during the pandemic, because there are clues in the data to what is driving antimicrobial consumption. In this graph, you see data from the community sector from the last 5 years, and the community sector, so primary care, makes up about 90% of the total consumption. You will see the baseline 2019 data in the bar far to the left, then followed by a very considerable decrease of over 18% that we saw during the pandemic's first 2 years, followed by this rebound back to pre-pandemic levels, even with a small increase in the most recent years. If you look closer, you will see that the largest drop in consumption in 2020 and 2021 was for penicillins and beta-lactams, and less so for other antimicrobial groups. So the decrease was mainly seen in antibiotics commonly used for respiratory tract infections. This is an area where we know that usually there is quite a lot of overprescribing. Next slide, please. So during the first year, so between 2019 and 2020, all but one country had substantial decrease in consumption, but the size of this decrease clearly differed between the countries. We noted that the largest proportional decrease was seen in countries that had comparatively high pre-pandemic consumption. You see that very clearly depicted in the scatter plot to the right here, where the x-axis shows the proportional decrease and the y-axis the baseline 2019 values. We know that during the first year of the pandemic, there was widespread implementation of non-pharmaceutical interventions, such as movement restrictions, reinforced infection prevention and control. And this seemed to impact the circulation of non-COVID-19 related respiratory tract infections. You might remember that there was hardly any influenza and also very low levels of other infections such as common colds, etc. in 2020. And this could of course impact prescribing, especially in settings where overprescribing for viral illness was common previously. It could also be that movement restrictions impacted access to healthcare for less serious and self-limiting illness that would not justify antibiotic use in the first place anyway. And this is of course only speculations, but it still indicates that the reductions seen were at least partly explained by reductions in unnecessary consumption. Next slide, please. So going back to this previous graph, we know that there has been a surge in infections in the past 3 years that could partly explain the rebound that followed. But this rebound could also represent a lost opportunity to strengthen prudent antibiotic use, helping maintaining the lower level of consumption over time. Next slide. Let's look at the second target that is related to the WHO AWARE classification, setting a goal of having at least 65% of the antibiotic consumption belonging to the access group by 2030. And you will note that this is slightly more ambitious than the original 60% threshold prescribed by WHO, but lower than the 70% threshold suggested at the United Nations General Assembly in 2024. I would say also here there is room for improvement at EU level. We are actually again moving in the wrong direction with a lower proportion of access group antibiotics in 2024 compared to 2019. So to summarize, we are still far from making the progress needed to reach the EU targets by 2030. So this really strongly calls for increased efforts to reduce antimicrobial use at all levels of healthcare in the EU and EEA. Next slide. But then, why is this important? Let's take a step back and remind ourselves that antibiotic use is driving antibiotic resistance. Let's remember my first slide about 35,000 people dying each year in the EU and the substantial cost to both communities and healthcare systems. Here I'm showing you some results from an analysis that we have done with data from ESACnet, but also antimicrobial susceptibility data from our sister network EARSnet that is focusing on surveillance of antimicrobial resistance in the EU-EA countries. Here we're looking at antibiotic susceptibility data from invasive E. coli infection. So a very common infection, but nevertheless serious. This is patients with bloodstream infections. On the other axis, we see antimicrobial consumption data from ESACnet. Each bubble here represents one country, and we see a very clear correlation between the level of consumption and the probability of resistance. We can see that countries with lower antibiotic consumption also report a higher proportion of E. coli still susceptible to fluoroquinolones, third-generation cephalosporins, aminoglycosides, and carbapenems. So countries with a lower consumption of antibiotics are also able to maintain a more favorable resistance situation. And we also found similar associations for several other individual bacteria antimicrobial group combinations, making this a very consistent observation. So the more you use it, the more you lose it. Next slide. And we know that interventions targeting antibiotic use are very effective when it comes to preventing excess mortality and also for economic gains, both related to healthcare expenditure as well as productivity gains. This is a study by OECD based on data from ECDC, and you will see that 2 of the interventions with the highest impact on both life saved as well as money saved is related to antibiotic stewardship and prescribing interventions. This is my last slide, and I really welcome you to have a look at this OECD report that is providing a very comprehensive overview of antibiotic resistance and the interventions necessary to combat the problem, really nicely underpinning the importance of antimicrobial stewardship activities. Next slide. So with that, I would like to thank you for inviting me to present at this meeting. Please do not hesitate to reach out to me if you have any questions, and if you have some time, you're more than welcome to explore our resources and our data online. Thank you.
Thank you very much, Lotte. And I think it was a wonderful view of the European work in this area, and with the very relevant analysis and correlation of data, which is always something that is expected, but difficult. And sometimes we feel that we are far away from having this important analysis correlating resistance and consumption, of course. So next, we are going to hear Delphi Goshes. She's a veterinarian, the data management officer for antimicrobial use at the Antimicrobial Resistance and Veterinary Products Department at the World Organization for Animal Health. She works in Paris at the headquarters. Her main role is leading the transformation of the antimicrobial use database and supporting the global data collection on antimicrobial use in animals. The most valuable part of her work is the interaction and support provided to WAH members in their antimicrobial use report. So thank you, Delphi. We are going to hear about ANIMUSE, the global antimicrobial use database in animals.
Thank you very much. Just to confirm that you can hear me and that you can see my presentation in the right mode.
We can hear you, and we can see the presentation. Thank you.
Thank you. As it was said, I'm representing the World Organization for Animal Health, previously known as OIE, now as WOA. I'm working under the AMR and Antimicrobial and Veterinary Products Department. And just before starting, because I'm not so sure that everyone in RAGNA really knows about WOA, so I just want to briefly just have one slide of what is WOA. And this organization has been existing for 100 years already. We celebrated our 100th anniversary last year. And the main focus for us is the monitoring and disseminating knowledge of animal diseases around the world. We account for 183 member countries and territories. In this map, you can see all our regional and sub-regional offices, while the headquarters is in Paris. I will not go longer into this, but just wanted to have an overview of how it looks, the organization, and how many members we had. So after this, I will just jump directly into the topic of ANIMUSE, which is mainly the main topic for today. So ANIMUSE, what is ANIMUSE and why am I presenting this today? ANIMUSE stands for the Animal Antimicrobial Use Global Database under the quadripartite WHO, WOA, UNEP, and FAO. WOA has been dedicating the work on the collection of antimicrobial use data around the world for animals. And since 2015, we launched our data collection. And this data collection was based in our global international standards from WOA basically the terrestrial animal health code that you can see here and the aquatic animal health code, specifically for chapters that are related to the monitoring of the quantities and usage patterns of antimicrobial agents in animals. And these chapters and these health codes are being voted by every member in WAS assembly. They've been first adopted in 2008. And there was a revision in 2012 to see if countries were actually implementing this. In order to help countries to implement this, that's why WOA launched the first round of data collection in 2015. Since then, we have been reviewing, updating, and we also created the portal because at the beginning we started with Excel. And in 2022, we launched the portal, which is global, the global database in Animus. You have the link here on the top, and you will see through my presentation some QR codes that you can also access. This map that you see here is the usual, I would say this is the last one from the 9th report. Every country that you see here in orange is a country that has participated. So far, I think from the quadripartite, we are one of having a very huge participation from countries. In every year, on an annual basis, we have around 150 countries participating, and around 120 countries providing us with antimicrobial use data for animals. When you go to Animus, you might be wondering how our reports look like. So the PDF version that you will always find it since 2016 when we launched our first annual report. So that will be our PDF versions. This is how we started. However, now when you go to Animus, you will have two versions of the report. One version is the PDF, and in this version is the one that I have on my right of the screen. You will have three main sections. One section is just giving you an overview how many countries participated, how many countries are using antimicrobials as growth motors, what are the barriers for countries for not providing antimicrobial quantities. And then we usually make a focus on the target year for that specific round. For example, in the previous one was 2022. So that's the latest report that we had, an analysis on 2022 data from 107 participants. Because even though all countries participate, some of them might not be some reliable, or there are some uncertainties on their data, so they are not included in the annual report. But for the rest, most of them we actually included in the report. Then we have a trends. Usually we focus on 3 years, and then you will have it here. The only exception for the advantage for the PDF report is that you will have some insights from WOA, some analysis, some contextual information. But the disadvantage is that usually for the PDF is something that is static. All the data extraction happens at a particular point in time. So for example, in this time was from November 2024, when we did the extraction from Animus. While we have another version, is the one that you have here on the left, is the interactive report. The interactive report, you will find it in Animus directly. And here, all the data is the most updated one. And every data is being refreshed every single hour. So for example, if a country that provided historical data for some reason updates the data and let us know, we confirm that this update is necessary, then within 1 hour, you will have the most updated information. But you will not have some contextual information, you will just have the tables and charts. And then just encourage everyone to go to Animus. When you go to the website, you will have some resources. You will find the questionnaire, how it looks like, that, as I said, was based on WOA standards, the guidance, calculations, and most importantly, we have an additional tool for all countries on how to do calculations. That was one of the impediments countries alert us since the beginning, that the most critical thing for them was actually how to calculate this and how to adequate this to WOA template. So while in Animus we have a tool which is more dynamic, more friendly and automatic, we also have the Excel version that is available for anyone, even if they are not having a login credentials in Animus. You can go and you can actually see what is here. You might be wondering who actually submits the data, and I think this is important to highlight in the RAGNA meeting, because you are mainly the agencies authorizing veterinary products or human products in the countries. However, to whom we contact in the countries are usually the veterinary services, usually under the Ministry of Agriculture of the countries, and is the delegate. So you see here all the responses through all the years. Who is responding to WOA? You see that delegates are not the ones, because those are like having more political and a political approach in the country, usually the heads of the veterinary services. But the one that you see here, the orange in the middle, are those that mainly provide the information, and those are the focal points for veterinary products. What focal points for veterinary products? Usually, they've been appointed by the delegate of a member country, and most of the time, we have seen that they are the heads of the regulatory authorities for veterinary products, but it's not always the same. We have seen some cases where the agency is completely outside of the veterinary services, and the head, the focal point still in the veterinary services. So we are expecting the focal point to contact the network at the national level to collect the data and then submit. We have very good examples of this type of work. For example, in Nigeria, we know that this has been a very good work, and the focal point contacts the agency that then submits to the veterinary services, and then they submit to us. And we have also seen some approaches. For example, you will see a presentation later from Bangladesh, and where they succeeded. We granted access to Animus while we keep the veterinary services having access to Animus. We also did the same for Egypt and other countries. Just to highlight that in the past, most of the countries were telling us, well, we do not provide the data to you because we're not having a good cooperation with the agency that authorized the veterinary products. And because it's under the Ministry of Health or others. So this has been reducing through the years, but still around the world, we have 9 countries that are classified as this. So we hope that this coordination in the country it's strengthened, so they can provide the information and to actually have trends and analysis through Animus, and to also the antimicrobial quantities to be analyzed by the animal biomass, so they can have their own ranks and have their own benchmarking around the world. Then I will just go very briefly here for there is room for improvement of antimicrobial use. Because we are still seeing that there are some countries that actually keep using antimicrobials as growth motors in animals. And this is mainly in 2 regions, I would say Asia and Americas, but in Americas is the region where we have most of the countries saying that they use growth motors, rather than when we compare to those countries saying that they do not use growth motors. I'm just making a point here because we have observed also that around the world, the agencies that authorize veterinary products are not usually the ones, it depends on the regulation of the country, not usually taking charge of those feed products that contains antibiotics, and they are being in charge of other countries. And sometimes we do not get the information on the feed additives that contain antibiotics. We have made some approaches to certain countries, but just for you to know that when we analyze the data from animals, oral products, especially for feed, are those that are the majority in total quantities. So we, as much as possible, we try to include these agencies when they are completely outside of these regulatory systems and outside of probably some veterinary services. At a global view, when we analyze antimicrobial quantities adjusted by their animal biomass, and the animal biomass is mainly coming from animal population, reported to WAHIS, and production data from FAO-Stat, and then we do some calculations to obtain the animal biomass. So when we adjust this and we are able to compare countries to countries, regions to regions, and trends over time, we have observed that in the period from 2020 to 2022, most of the countries decrease the antimicrobial quantities, except for the Middle East, that even if one of the regions, well, the region that uses the less, but it's we have seen an increase. And the region that uses the most so far is Asia and the Pacific, and we have observed a little decrease here. However, we are attentive to fluctuations over the time because, as you know, COVID, and it was already said by the previous presentation, COVID time is a little bit exceptional. So when you go to Animuse, you can actually see more years and more trends. But for the report, we tend to focus only on 3 years. Then very quickly, I will go to the next steps for Animus. And just to let you know that around the world, most of this is the big pie chart that you have here is the data sources that countries uses to provide us with data. So you see that most of the countries are giving us either sales data here or import data. So there are some limitations with import data. And when you go into every region, you can see that the region that is usually using most sales data is Europe. But for countries like Africa and Asia and some parts of countries in Americas are keep using import data. And this is related to the next 2 points that I'm going to discuss right now, because there are some limitations. The first limitation is that so far for Animuse, we have 3 reporting options on how to collect the data. We collect the data by antimicrobial agents and type of uses. We collect the data distinguished by group of animals. And by group of animals, I don't mean animal species, but rather the big group of terrestrial food-producing animals, aquatic food-producing animals, and non-food producing animals. And then by routes of administration. But the next step that we want to do at WOA is that next year we want to launch the data collection stratified by animal species. And we have observed, and also from feedback from experts, that it's not possible to do this with import data. So we are rather encouraging countries and motivating them to collect the data directly from the private sector, from mainly the marketing authorization holders. So they are the ones estimating how a specific product is going to be sold or used at the end. To be used. So these are the new classifications. We are in a testing period, and hopefully next year we'll be launching this. And we are encouraging countries to move from import data to actual sales data. Another part is that we are working with countries on to producing antimicrobial reports. And in this side, we already had 2 meetings, one in Africa, one in Asia. Then we are going to have in a couple of weeks, another one in French-speaking countries in Africa. So with selected countries that we know they are very good. So basically we are giving them the tools on how to analyze their data, how to prepare a national report, because around the world, we have very few countries doing this. It is mainly concentrated in Europe, and we want that more countries have access to this, take ownership and power with the data, and take decisions based on data. So we are giving them some tools. We are giving them some examples on how to do this analysis. And we believe that this is the country's voice for change in the country. We are currently following with some of them to develop communication materials, and probably at the end of the year, we can have the first countries under this approach to have their reports in Animus and in their country portals as well. And finally, we'll just try to remind a little bit on the political declaration on AMR that was adopted last year at the United Nations Assembly. And you can access through this QR code or the political declaration for the animal sector. And I will just come here to one specifically that is related to Animus, which is the reduce of antimicrobials in animals, and is specifically point 69 that has stated that countries should be significantly reducing antimicrobials. And the way how countries can actually do this is through Animus, because as I was saying, we already provide the animal biomass. So it's not only for you to understand how much you've been decreasing or increasing, which are the antimicrobial classes that you use the most, but also you have the possibility within Animus, when you have the credentials to log in as a country, to actually see where you are ranking compared to other countries and compared to the global figures or regional figures that you have. So I would just encourage all of you, if you're an agency and you have not, you are not aware that this is happening, just to make contact with the focal point or the delegate from MOA to make sure that this is happening. And if there's no relationship, just to encourage you to reinforce this and to make sure that the country participation is there, since you will have a lot of advantages when you are putting this information there. So you don't only see your data, but you also will be able to compare your data with others. Well, we are not revealing others' data, but you will be able to see where you are ranked compared to others, other data. Thank you.
Thank you, Delphi. It was a fantastic presentation, and you showed us a clear picture of the complexity of antimicrobial use surveillance in the veterinary field. I think you showed us some very clever ways to face the challenges of having so many different stakeholders and systems all around the world. Thank you very much. And now we move forward, and Professor José Artur Paiva, who is an internal medicine and intensive care specialist at the second largest hospital in Portugal, in fact, and he is the head of the intensive care department, and he has been working in infection control and antimicrobial resistance for a long time, and has in fact been the coordinator of the national plan, the first national plan in Portugal. He was the director of the National Program for Prevention and of Antimicrobial Resistance from 2010 to 2013, and then the national director of the National Program for Prevention of Infection and Antimicrobial Resistance from 2013 to 2016, and again from 2024. And he will be speaking about the surveillance and data collection. Do we need to change it to improve interventions and results?
Well, thank you very much. Good morning to everyone, and thanks very much for the invitation. I will try to share my slides, and could you just please tell me if slides and sound are okay?
Perfect, perfect.
Thank you very much. So my task, as has been asked by Dr. Carlos Lima House, is a bit of a criticism, I hope constructive criticisms about the surveillance and data collection. But the first words are actually for praising and thanking, because the fact that we have ISAC-NECT and we have GLASS-AMU is splendid, is fantastic, and thanks to everyone that contributes to that, as we all do. Again, my task is to ask if they are perfect, if they are strategic, if they are enough. And let me go through a few questions. The first one is the denominator. As you know, the primary indicator is total consumption of antibacterials for systemic use, expressed in DDD per 1,000 inhabitants per day. And of course, this is very good for the community, but for hospitals, we do believe that the denominator being hospital admissions or occupied bed days would be much more interesting. And actually, using both of them, hospital admissions and occupied bed days, because as you know, the shift and variation of lengths of stay gives implications in one and the other, which are actually very different. When we have seen that when we analyzed COVID-19 pandemic period. The second question is actually the numerator and the fact that we are using DDDs. And as you know, for many persons, especially hospital professionals, and I would say that even more in intensive care, we have problems about what the normal dose is considered, and we more and more use PK/PD's ideas that in certain types of patients we have to promote higher doses to attain a better effectiveness. And the other problem is that DDDs is quite technical, I would say a bit pharmaceutical. And there are simpler things like days of therapy or lengths of therapy, even simpler, which could be more appealing to practitioners. Again, when we take the secondary indicators, we see that the numerator is a bit confusing because it puts together antibiotics that are extremely different. We have antibiotics which are short spectrum, antibiotics which are broad spectrum. It seems that being newer or recent implies on being on the numerator or not. And I guess you agree that tidazoline and daptomycin are rather different than polymyxins or third and fourth generation cephalosporins. So again, the clinical grouping of antibiotics is a bit confusing for clinicians and not very clinical. The third problem, which for me is very important, is the lack of standardization of populations. As you know, in any indicator, population is the most important definition, is the most important characteristics. And we have public and private, or public or just public in some. The classification of what is a nursing home and a long-term care facility is different from country to country. The definition of what a hospital is also different from country to country. And when we take community, we have dispensing, reimbursement, distribution, wholesales. So again, it's a bit different, certainly very different from country to country. The fourth problem for me is visualization. When we take the characteristics of the indicator, this is the most recent one. And in terms of the presentation, we seem to be hesitating between vertical and transversal, meaning comparison among countries, or comparison longitudinally or transversally inside each country. But when we look at the graphs, as you can see, the trend, the line trend, is a small part of the thing. And we do not have an estimation of significance. And again, we do not have a link with interventions that have been performed in those countries. And on the other hand, if we compare countries, as you can see on the left-hand side, again, it's very difficult because the population is not standardized. When we took visualization, I feel that the absence of the target in the chart has room for improvement. So as has been said, we now have clear targets for the European Union, targets for each country inside the European unit, temporal targets. So the idea of having a visualization that presents those targets, that give us a kind of control charts or Shewhart graphs or any other type of graphs that can make the distinction between a common cause variation and a special cause variation would be, in my idea, very interesting. And as we lack the benchmark capability, we also lack the real decision on the virtue of this longitudinal evolution. The benchmark would be very much promoted if we had a standardized antimicrobial administration ratio. As you know, 30 or 40 years ago, we've done that for mortality assessment. Standardized mortality is now something that we use in hospital, namely in the critical care patient. As you also know, the Centers for Disease Control and Prevention in the US, with the work of Dan Pollock and Catherine Van Zanten, has promoted this idea of standardized antimicrobial administration ratio. And this for me is very important if we really want to have benchmark. And in my opinion, benchmark is really a driver for improvement. And if we don't do it, we risk that the worse becomes worse and the better become even better. The second problem is the absence of measurement of change. We are speaking very much about data. I'm sorry to say, I don't think we need data. We need knowledge to take action. So we need to move from data to knowledge, to wisdom, which is even better than knowledge, and to take actions, as Peter Drucker has said. The importance of information is being able to take the right action, to decide the right intervention. So I feel that when we give indicators, we have to promote and show this quality gap, disclosing the quality gap attitude, and link data to change. Again, the sure charts, the commitment with a quality plan, the analysis of the quality control zone, and the promotion of interventions for a quality improvement zone, which soon will become the new quality control zone. So this idea of linking data to change and not being satisfied with just having data is for me very important, and has been stressed by the gurus of quality, as you know, Peter Drucker saying that success always obsoletes the very behavior that achieved it, which is a very elegant way to say this. So we need dynamic measurement. We need the annotation of timing of interventions. We need to show targets and control limits. We need to promote feedback to providers. And we need to measure change, not just to measure how we are, but what we have changed. And finally, which is the real challenge, I think, is the idea that in antibiotics, and this is very important for clinicians, and I would say also for the citizen, is not just to measure quantity, but to measure quality. This is the quantum leap. This is very difficult. Both indicators are quantitative, of course, but the difference is that quality indicator has a value on its own, and quantitative indicators, they only gain value when comparisons are being made, even with the past or with the others, but they need comparisons to gain some value. Quality indicators is what we really need, and quality indicators, we hopefully should have process indicators, outcome indicators, and equilibrium or balanced indicators to measure the interventions and the impact of the interventions. So there are a few problems: the denominator, the numerator, the value of indicators for the clinician, the lack of standardization, the visualization, namely with the target, the lack of benchmark, the absence of capability of measuring change and attaining quality indicators, and of course, timeliness. 1 year is too much for timeliness. We and others, we have worked together to complete this picture with other sources, or even the same sources, other presentation, other efforts. The INFARMED for several years with the help and participation with the National Program on Infection and Antimicrobial Resistance Prevention. We have worked together trying to sort out some of these lackings. Namely, we have produced and feedback to providers data on hospital antibiotics per patient days, and also for discharged patients. As you can see here. Sorry for the Portuguese in the slide. And we have pulled up comparisons, past and present, for the same hospital, the specific hospital with a national result, and the specific hospital with the medium value for the hospitals of the same dimension and typology. Again, trying to promote benchmark and then collaborative improvements. And this has been done, I show an example, but this has been done for the last 8 to 10 years. And if you go even micro, we are also engaged in some European projects like the Drive AMS, in which we try to define what is the quality gap, and we try to use simple metrics like PPS and define that quality gap, addressing it by pulling up interventions, namely behavior change interventions, and pulling up indicators that measure the process of the change and the impact of the change, and then feedback to providers. This is more micro, but is change linked, as I told you. So to try to respect my time, my main message is that measurement as a fundamental place in antimicrobial stewardship, and I have that bias. I believe that antimicrobial stewardship is the movement that will make the difference in terms of antimicrobial use. Both the short cycle antimicrobial stewardship, improving the prescription, but also the longer cycle of antimicrobial stewardship, changing the prescriber and the culture of prescription. So we need to use quality indicators. This is a challenge. We need to move to quality indicators, trying to use those that were published in the literature and that match our interests, but also to develop indicators that are useful for our own context, to use structure, process, and outcome, and even balanced indicators, and to promote dynamic measurement and feedback. So as a global and final slide, I believe that we need these standardized yearly ISAC-NET and GLASS-AMU report. That is very important to unite us all together. But we also need national, more frequent reports like the trimestral INFARMED PUP0 report. And we also need to go more micro and have a shared system of customized local health news quality indicators. And on top of this, we need two other things. We need an all system one health report, really integrated, and this is very important. And locally, we need to attain an integrated vision of antimicrobial consumption, antimicrobial resistance, and infection control and prevention practices, because it is this integration that is needed to understand the real target, which is to decrease antimicrobial resistance by promoting better healthcare, including better antimicrobial use. And the best way to avoid antimicrobial use is to avoid infections. Thank you very much.
Thank you very much, Professor José Artur. It is always a pleasure to hear your wonderful and very well thought ideas, which are impactful and I think are quite visions that we need in order to move forward in surveillance and, of course, ultimately in the goal to reduce antimicrobial resistance. So thank you. And we now go to two presentations with the sharing of experiences from very far sides from each other. First of all, we are going to hear from Dr. Sabrina Yasmin. She has been serving at the Directorate General of Drug Administration in Bangladesh for the past 12 years. She is a former Fleming Fellow in AMU-ANC surveillance, and she is a recognized expert in antimicrobial resistance, policy, and surveillance, with substantial contributions to strategy development, guideline preparation, and awareness initiatives. As the national focal point for antimicrobial consumption and antimicrobial use surveillance, she has led Bangladesh's reporting to WAH NMUs. She will talk to us about the experience sharing of human and veterinary antimicrobial use surveillance in Bangladesh. Thank you very much, Dr. Sabrina. Sorry for the delay. Sabrina, are you with us? Good morning, Sabrina. Can you hear us? Está no chat.
Não está nada no chat, mas ela está a escrever, pois é. Deve estar a aparecer qualquer coisa.
O som está aí lá para casa.
No, Sabrina, we can't hear you.
Am I audible?
Yes.
Yes, now you are.
Oh, thank you.
Thank you. Do you see the slides?
Yes, yes, I can see.
So, the floor is yours.
Thank you for giving me the opportunity to present our experiences in the human and veterinary antimicrobial use surveillance in Bangladesh. Next slide, please. As we all know that antimicrobial resistance is a pressing global health and socio-economic crisis, and there is a association between antimicrobial use and antimicrobial resistance. So antimicrobial use monitoring is important for policy decision to reduce antimicrobial resistance. Directorate General of Drug Administration is the national regulatory authority for both human and veterinary medicine in Bangladesh. And as the National Center for Antimicrobial Use Surveillance in Bangladesh, DGD has been conducted the antimicrobial use surveillance for both human and veterinary antimicrobial medicine, and we report to WHO GLASS platform for human antimicrobial use surveillance, and we also report to WA Anonymous platform for antimicrobial veterinary use surveillance. And I'm very happy that Dr. Martina from WHO and Dr. Delphi from WA, they are present here, and we work with them for this to surveillance system. Next slide, please. At first, I'm going to present our antimicrobial use surveillance system for human antimicrobials. We use the WHO GLASS methodology for national surveillance of antimicrobial use. Previously, this antimicrobial use surveillance was defined as the antimicrobial consumption surveillance, but in this year, WHO has defined the antimicrobial consumption surveillance as the antimicrobial use surveillance in medical level, and there is another types of antimicrobial use surveillance which is called antimicrobial use surveillance for patient level. So this data source provide a proxy estimate of use of antimicrobials, and in Bangladesh 98% of the medicine are locally manufactured, and our marketing authorization holder and manufacturer are the same in Bangladesh. So we collect this sales data from our distribution channels, and it covered the 100% of locally manufactured antimicrobials for human use. And our methodology, we calculate the total amount in defined daily dose per 1,000 inhabitants per day. Next slide, please. In this slide, you can see our overall national consumption. In our previous colleague from ECDC, she presented the overall consumption pattern of European Union. Our consumption trend and pattern is totally opposite of the European Union consumption pattern. From this slide, you can see that in 2019, our overall consumption was 28 to 27 daily defined dose, but in COVID-19 pandemic period, it increased, and in 2021, you can see that it was 62.36 daily defined dose. So it is reported that high consumption of antimicrobial medicine, especially antibiotics, in the COVID-19 pandemic period in Bangladesh. But in 2023, it decreased a little bit. Now it is 33 daily defined dose per 1,000 inhabitants per day. Next slide, please. In this figure, from the left one, you can see that the antibacterial for systemic use, that is the antibiotics, these are the highest consumed antimicrobials in our country. And from the right side figure, you can see that the other beta-lactamase antibacterial, this is the highest consumed group, and second one is the macrolides. Next, please. In our country, the highest consumed route of administration of antimicrobial is the oral route of administration. But in oral route of administration, from the cephalosporin group, you can see that the highest consumed cephalosporin group at the third generation cephalosporin. It covers almost 40 to 60%, but for parenteral route of administration, the use of third generation cephalosporin, it almost covered the 90% of the national consumption. Next slide, please. The recent United Nations General Assembly goal is to ensure the global target of at least 70% use of access group antibiotics by 2030. But it is very difficult for Bangladesh because from our antimicrobial use surveillance system, we see that worst category antibiotic consumption in our country is 52 to 62%, and our access category is 28 to 32%, and reserve category is around 2%. So this high amount of worst category consumption is a very difficult situation for our country, and we need more policy level decisions to reduce this worst category consumption. And for parenteral dosage form, you can see that worst category consumption is almost 80 to 90%. Next, please. This slide present the drug utilization 75%. That is the highest consumed antimicrobial, which covered the 75% of national consumption. And from this table, you can see that the cefixime, azithromycin, cefuroxime, and beta-lactamase, then ciprofloxacin, metronidazole, doxycycline, cefuroxime, flucloxacillin, amoxicillin, and cephradine. These 7 to 8% antimicrobial that covered the 75% of our national consumption, and the highest consumed oral for oral route of administration antimicrobials are the cefixime and azithromycin. And from this list, cefixime, azithromycin, cefuroxime, ciprofloxacin, and cefuroxime. These are from worst category antibiotics. That's why in our country, worst category consumption is so high. Next, please. This slide is for parenteral route of administration, and it only 2 to 3 antimicrobial medicine which cover the 75% of national consumption for parenteral route of administration. And you can see that 50 to 70% consumption covered by only ceftriaxone. And the second highest consumed was the moxifloxacin and metronidazole. So to reduce the use of ceftriaxone is an issue for our country. Next, please. So in our country, Directorate General of Drug Administration, we conducted the antimicrobial use surveillance, and there is another organization, IDCR, under the Directorate General of Health Services. They conducted the antimicrobial resistance surveillance. And recently, we analyzed these two data, antimicrobial use and resistance surveillance, in our recent workshop. And we have prioritized antimicrobial medicine for our country, which are critically important. And we have discussed that we need to restrict some antibiotic from worst and reserve category, like fosfomycin oral dosage form, levofloxacin, and linezolid. And we also need to promote some access category antibiotic, like for respiratory tract infection in our country, the use of azithromycin is very high. But we can shift this use to doxycycline, and we can also promote the use of doxycycline, because from our antimicrobial resistance surveillance data, we found a very good susceptibility in doxycycline. So we discuss about several issues, that how we can reduce the use of worst category consumption in our country. Next, please. And we also incorporated legislation in our recent Drug and Cosmetic Acts, which was approved by the Parliament in September 2023. And we already implemented this act, and as per this act, selling of antibiotic without prescription is prohibited, and the punishment is 20,000 taka. And last year, we filed a case against 157 pharmacy for violating this act, and the punishment was 7,75,500 taka. So it is going on. Next slide, please. We also incorporated the red identification mark on the primary and secondary packaging of antibiotics for creating the public awareness and easy identification because the patient, they don't understand in their precision which one is antibiotics and which medicine they need to complete the full courses. So, and this initiative was highlighted by WHO, and they publish it in their feature stories. Next, please. We also conducted different awareness program with the drug seller, with the pharmacist, and also with the physicians. And from January to October 2024, we conducted 173 awareness program covering the 32 districts in our country. And recently, the government is updating the essential medicine list, focusing on the WHO award classification of antibiotics. Next, please. We also develop different educational materials only focusing on antimicrobial resistance for our children, and we took initiative to incorporate the AMR issue into the secondary educational curriculum, and which is also highlighted by WHO, and that was our very successful initiative. Next, please. Now, the antimicrobial use surveillance for veterinary medicine in Bangladesh. Last year in 2024, this is the first time we reported the sales data to the WA-NMS platform, and Bangladesh was the 43rd position among the all WA-listed countries, and tetracycline was the highest consumed antimicrobials for Bangladesh. Next, please. From this antimicrobial use surveillance data, it was highlighted that chlorotetracycline, neomycin, ceftriaxone oxytetracycline, metronidazole, sulfametazole, ciprofloxacin, and enrofloxacin covered the 79% of our total national antimicrobial use for veterinary medicine, and 21% of the total quantity sold belongs to class considered to the WHO medically important antimicrobials. So we discussed this issue in our policy brief, and we took some regulatory actions. Next, please. DGDA has banned 34 antibiotics in veterinary use that's critically important for human, like all doses form of colistin, fosfomycin, azithromycin, all combination of ciprofloxacin, 23 combination of axis group, and 5 combination of WAS group. But still, we do not ban the single doses form of ciprofloxacin on the basis of our antimicrobial use data. Next year, we are going to ban the single doses form of ciprofloxacin, levofloxacin, and moxifloxacin, because these are very critically important for human use. So next, please. So that was all about our experience. So thank you for giving me the opportunity.
Thank you very much, Sabrina. It was really interesting to see your work, which is something that we have to stress. It is an important work, and sharing that experience with us. Very quickly now for Dr. Svenja Zender. She's a veterinarian with a medical specialization in pharmacology and toxicology, and also a lecturer in these areas at the School of Veterinary Medicine in Berlin. And since November 2024, she has been the group leader of the post-marketing group in the veterinary medicines department. The drug resistance unit, which Svenja led from 22 to 25, is responsible for implementing data collection on the sales and use of antimicrobials in veterinary medicine, as required by Article 57 of the regulation of the European Union. She will address the monitoring of the sales and use of antimicrobial veterinary medicines in Germany, the achievements and challenges. Dr. Svenja, the floor is yours.
Thank you very much for the kind introduction. Can you hear and see me, and can you see the presentation?
Yes, I would just ask you to put on presentation mode if it is possible.
Pardon?
The PowerPoint in presentation mode.
No, you can't see it?
I think you have to share the screen instead of sharing the specific presentation.
Okay, sorry for that.
Sorry.
Okay. So, next try. Fenster, gesamter Bildschirm, okay. So, does it work now?
Not yet.
Not yet. That's a shame. So maybe you can just...
So I've been told for you not to share the presentation, but share the desktop, the complete desktop.
Okay. But well, it doesn't seem to be possible for me because it also...
Can we share the presentation from here?
Yeah, that would be nice. Thanks a lot, because I guess it just doesn't work. Sometimes our federal computers are a little bit difficult to handle. Sorry for that.
Danke.
Okay, so thanks a lot.
Okay.
E agora temos aqui.
Temos que escape. Ok.
Isso, é 6. Exato. Fica embaixo.
Okay, wonderful.
Yeah, okay, good.
Thank you very much. So thanks again for giving me the opportunity to share our experiences in Germany with monitoring sales and use data of antimicrobials veterinary medicines. And next slide, please. So I think, as you know, Germany is embedded in the European Union in the regulatory law and also in the European strategies. And as we heard before, we have the European One Health Action Plan against antimicrobial resistance. This is also very important for veterinary medicine. And just another click now, please. Yes, and another click. So that's a shame. If I could do that myself, it would be a little bit easier. And the next click again. So we have the farm to fork strategy, and we also have a goal to reduce antibiotics in veterinary medicine, especially for farmed animals and agriculture, by 50% until 2030. So some of you may know this, but that's really the big goal we have to achieve in our sector in veterinary medicine. So next slide, please. And to reach that goal, I think the regulation 2019-6, the big veterinary European regulation, helps a little bit. That had two main objectives. And one of it was reducing administrative burden, but the other one was strengthening the European measures in the fight against AMR. So we have a ban on prophylactic use in groups of animals and restrictions on the metaphylactic use of antimicrobials, and also a reinforced ban on the use of antimicrobials for growth promotion. And a click, please. The possibility to reserve certain antimicrobials for human use, and another click. We have now the obligation for the European member states to collect data on sales and use of antimicrobials. So next slide, please. there are different surveillance programs concerning especially sales data and use data. So in veterinary sector, we have some existing systems had before. So on the national level in Germany, we have collected sales data on antibiotics since 2011, and we have a benchmarking system, which I explain a little bit later more in detail, since 2014. In Europe, there was the ESVAC project. We have heard of ESVAC before, so that's the same in veterinary, in the veterinary sector, and that was on a voluntary base. Next click, please. And newly implemented since 2023, there is a mandatory collection of sales and use data on national level, and all member states report this data to the European Medicines Agency, according to Article 57 of Regulation 2019/6. And the first report, including all this data, was published in March this year, so 2025. Another click, or next slide, yes. So before there were the ESVAC reports, now we have ISUA-VET reports, and you can download them on the internet. You can find the link here. Just Google ISUA-VET and EMA, European Medicines Agency. So we will find the last report from last year, and the annual report for the data of 2024 is under work at the moment. So it's under preparation. Next slide, please. Or next click. So you next slide is fine. So you can just see many nice figures in it and go into deeper. I think in view of the time, I will just shorten this a little bit. And here's some data from our national surveillance of our sales data. So since 2011, as I said before, we collected these data, and you can see that until 2023, there was a nice reduction of around about 70% in the amounts of sold veterinary antibiotics. So these are really just the amounts in tons, and they are not corrected to population data, which you would find in the ISUA-VET report that is population corrected. And the different colors here represent different classes of antibiotics. So as we saw before, I think in the presentation from Bangladesh, the tetracyclines also play a big role in veterinary medicine in Germany too. So next slide, please. And we also have an opportunity to look in the regional distribution of our sold antibiotics, because we have the special data encoded by the regions where it was sold. And you also see here really big differences in the colors of year 2011. And what is quite interesting is you see in the northwestern of Germany, these are traditionally production areas of farm animals there. So where we have high density of farm animals, also the sold antibiotics amounts are quite high. Next slide, please. And according to Article 57, now we also have to collect use data. So sales data is quite more easy because you have very professional marketing authorization holders or wholesaler who provide you with the data. But for use data, we really need to contact the veterinarians, or they have to send the data to us, and that's far more ambitious. So it's possible to have a stepwise approach in the European Union. And we first collected data from cattle, pigs, chicken, and turkeys in 2023, which you can find in the ISUA-VET report, which was first submitted in 2024. And next year, the antibiotic use of other food-producing species has to be collected. So we are preparing that at the moment. And afterwards, from 2029 on, the data of the use of antibiotics in dogs and cats and fur animals has also to be collected and afterwards reported to EMA. Next slide, please. And now I would just show you how our national surveillance works. We have our use data collection is, as I told you, made by the veterinarians. Veterinarians who treat cattle, pig, chicken, turkey have to send their data in our federal database called High Tier Database, and the BVL, which is the Federal Office of Consumer Protection and Food Safety, is the data manager. We collect the data, we validate the data, we make the quality control and report to EMA on an annual level or annually. Next slide, please. And what I just want to show you is our benchmarking system, which, well, I think picks up some of the ideas I heard now before, because it really worked quite nicely in Germany, I have to say. It was introduced in 2014. And so we have collected use data for certain farm animals since then. Targeted farms that have an above average use of antibiotics in comparison to other farms with the same animal production types have to set up management plans. So we have different production types: fattening animals, cattle, calves, chicken, turkeys, pigs, piglets. We started with them, and since 2023 we also added dairy cows, laying hens, young hens, breeding pigs, and suckling piglets. So the aim is to reduce the use of antibiotics for the therapeutically required minimum to the, So next slide, please. So the idea is, first, it only covers farms that exceed defined thresholds on animal numbers. So small farms are not involved in this benchmarking system because it's just too much work and it's not worth it. We would just really target big farms. And for each farm and production type, there is the average number of animals per farm analyzed and the number of antibiotic applications. And these two numbers are used to calculate the treatment frequency at farm level. So it's combined of number of animals and antibiotics given. And these treatment frequencies are sent to the BVL, and we calculate key figures and publicate them on an annual level. Key figures for the benchmarking. Next slide, please. Or next click, yes. And also, well, what is also considered is if you use third or fourth generation cephalosporins, fluocanalines, or colistin, they weigh more. So so your treatment frequency rises much higher if you use them much. So that should be helpful for directing the farmers and veterinarians to the right antibiotics. So next slide, please. So in this calculation of the nationwide key indicators, so all treatment frequencies of all farm levels are used to calculate the median and the third quartile. So the median is the key indicator 1 and the key indicator 2 is the third quartile. And if a farm exceeds the key indicator 1, a veterinarian has to be consulted and how to reduce the use of antibiotics. And if key indicator 2 is exceeded by a farm, an action plan is to be drawn up, which aims at the reduction of the antibiotic use. Next slide, please. So this is my last slide and also the conclusion. As you can see here quite nicely, we introduced the system in 2014, and you see the amounts of antibiotics sold by the year, different years, and we really had a quite obvious reduction of antibiotic sales after using the benchmarking system. So from our experience, you have the possibility to influence the quantity, but also the quality of antibiotics used in the areas where really high amounts of antibiotics are used. So pet animals, it wouldn't make sense at this level, we think, but in farm animals, it proved to be a good solution for Germany. So thank you very much for your attention. And yes, sorry for the technical problems I had.
No problem. Thank you very much, Svenja. and it was wonderful to see your impressive results. It's always good to end with a positive note, and I believe we are running out of time, so I think I can speak for all of us here and from RAGNA and from the speakers that we would be, of course, available to have you reaching us for any more information that you need. I believe the presentations will be shared, but we have no time for question and answers. So just to wrap up, I would say that, and it was fortunate to see the last couple of slides from Svenja, because they go really into what I think could be a wrap up of our discussion. So we need to improve the quality of the data that we are collecting, the surveillance that we are doing. We need to add things that we did not talk today, like food and the environment, water, waste, and taking that, but having in mind that we need goals, and we need to see the interventions and the changes that we are promoting in order to achieve those goals. That yellow, green, red graph that Svenja showed us is kind of a signal of what we need to do at local, regional, and probably global level. Thank you very much for all the work that all of you are doing in each of your places of work, different countries and different levels. Thank you very much, and thank you, of course, to RAGNA for having allowed us to have this opportunity. Thank you all. Thank you very much.
Thanks a lot. Bye. Have a good day.
Thank you.
Thank you.
Thank you.